Welcome back to American Warrior Radio, the place to get all the information you need about filing claims and being successful, and information that is valuable for veterans and their families, for all our listeners, no matter where you may be. And we know that we get outside the Space Coast with our broadcast here, and we are thrilled today to have Dr. Todd Panarese, a former Army medical doctor, very experienced in the cancer arena, works for Cancer Care Center of Brevard. And Doctor, we're going to talk about a few things, ask you a few questions here if we may, about, I think we'll start off with some of the cancers associated with Agent Orange exposure, which folks out there, that's really herbicide exposure. There were 3 or 4 different kinds of herbicides used in Vietnam to knock the weeds down, so to speak. Right. Some of them came in an orange barrel, so that's where the term Agent Orange came from. But there's some serious illnesses caused by exposure, and for the most part, exposure is for those who had boots on the ground in Vietnam. Although certain people who were stationed in Thailand, the Korean DMZ during a certain period of time in certain units, and then there's Johnson Island where they stored some of that Agent Orange stuff, and that's even harder to get from there, but it is very presumptive. Anybody who sat boots on the ground in active duty in Vietnam was presumed to be exposed to Agent Orange slash herbicides. And what do you think are some of the worst problems that are associated with that, Dr. Panarese?
Well, in case you didn't know, anybody didn't know, the herbicide used a substance that we no longer use here in the United States. It was banned. It was dioxin, and it was one of the byproducts of manufacturing the other chemicals that went in it. And the military dumped, I don't know how many million gallons of this stuff all over the place, all over that part of the world. And a lot of people were exposed to this really bad stuff, dioxin. And
it's an aerosol just coming out of the air.
Yeah,
being sky dropped.
Exactly, just in a mist form all over the place. Even the guys who were working with it through the barrels. I mean, this stuff is just really bad news stuff. And so they had since banned it for use in the United States. We can no longer use that. So I'm not surprised that having such a toxic substance being dumped on you for a number of years hasn't caused some sort of problem, and I'm frankly surprised it hasn't caused more oddball things than we normally see. But the things that we normally associate with Agent Orange and that the VA has recognized as being a problematic problem with exposure to that substance are a number of relatively common diseases that we see all the time. We're talking about lymphomas, we're talking about lung cancers, diabetes, soft tissue sarcomas. Not necessarily odd in the sense that we don't expect men of a certain age to get those things, but I think the VA has acknowledged that perhaps these are occurring more frequently in those men who are exposed to this agent. So we're seeing them now in this age group, who are especially here on the Space Coast, that are having these problems more often than we would possibly want to see.
You mentioned the Space Coast. I have to get this in. Why'd you come down? You're a Long Island guy. You've been, around the world kind of. Why'd you come and reside in the Space Coast? Just share with us that real quick.
Well, sometimes things work out of your control. I was working at Brooke Army Medical Center after I finished my residency in radiation. I'm a radiation doctor. And my wife is from San Antonio, so we went back to San Antonio to live for a number of years. And the job available at the time was at Brooke Army Medical Center as a radiation oncologist. So I was back to where I started from back in 1989. I was back now in 2000. And I was there for about 5 years, from 2000 to 2005. And I was a civilian, and like any civilians who are employed by the government, contracted by the government, there were other active duty personnel who were coming out of the pipeline, who were able to fill my position. And so that position went away. And we sort of had no place to go. It was like, okay, do we stay in San Antonio and kind of look for a job? Or do we sort of, let's do something kind of different and go to Florida? And so we went to Florida. That's exactly
All
how
right.
it worked out.
I love
we
it.
had my parents, or rather my uncle, my father's uncle, had a house on the West Coast that he had lived in, and that he died and left it to my parents. And it was sort of like the summer home that really nobody used. And we sort of took it over, and like that became our home for about 2 years or so. We lived there. Now my medical license was in Texas at the time. So I was flying back and forth every week, every Friday, every Sunday, to go to work.
That's a long commute.
That's a long commute. So I got very, my frequent flyer miles were large at the time. And we were looking for positions in this area, sort of anywhere. And it took a while to find the right spot until I got word that there was a position here on the Space Coast with Cancer Care Centers of Brevard, who I had interviewed with about a year and something before. There wasn't a position yet, but I had met Dr. Charles, who was the founder, and he's like, well, we'll keep you in mind. And that was the last I had heard of it for quite some time. Then I got word that there was a spot open. I called, I came, and 2 days later I was working. I was at my Merritt Island office.
To our benefit here on the Space Coast, for sure. You mentioned your radiation oncologist. For those of us that don't understand all this stuff, we kind of got an idea what radiation is. That's chemotherapy and things?
No, it's not chemotherapy.
That's chemical.
That is right. It's the chemotherapy is the medical portion. It's medicine. It's like any drug that you would buy, but we call it chemo because it sounds terrible.
It does.
Yeah, it does sound terrible, and it can sometimes make you not feel good. My job is the radiation portion. So I would shoot high-powered X-rays or some sort of radioactive, implant radioactive substances, or use radiation to treat cancer, to try to kill cancer cells. So I deal with mostly solid tumors. So if you have, like example, a lung tumor, prostate, sarcomas, things like that, I would be one of the guys you would want to see, because as barbaric as it sounds, we still need radiation, and which is an old way of treating. Frankly, they started doing this in the 30s or so, and we've gotten better and better at it. But we still have to use this method of shooting from the outside to a tumor on the inside to try to kill it. So we would sometimes combine the chemotherapy and radiation together as in synergy to try to sensitize the cells with the chemotherapy while my radiation tries to kill it. My radiation kills it by disrupting the DNA of the cancer cell.
And it's focused on the tumor itself.
It's focused as best as we can. There's no way, it's not like a laser beam, unfortunately. There's no way to do that because simply of the physics of what's coming out of the machine. It's an X-ray. It's just like you go for an X-ray for your chest. Same thing, only these machines are much bigger and the energy that's coming out is much stronger. And that's good because we get depth of penetration through the skin, through the tissue in between to get to the tumor where we have to go. So you get less dose to the skin and more dose to the depth. Years ago that was a problem. We didn't have very energetic X-rays coming out of the machines. So a lot of the dose went to the skin before it got to the tumor. And that's when you hear the horror stories of all these horrible skin burns and this and that. It wasn't because of the radiation, it was just because of the method that we had, the technology that we had at the time. We really don't do that anymore. We have a lot more sophisticated machinery, much higher energy X-rays that we can use, and we can focus by blocking out the surrounding tissue. And a number of ways to do it, really. We can use the sort of the way we were doing it 10 years ago, 15 years ago, was using lead equivalent blocks to make shapes of the tumor through the skin as a silhouette. And we would know the shape because we had a CT scan to tell us. And we would use that shape translated to these lead equivalent blocks, and we would shoot in a number of directions. We were limited to the number of directions we can shoot simply by time, because the machine would have to rotate. You would have to put the new shape in and do that area, rotate it again, put the new shape. So we were limited to the number of angles that we would shoot simply because it was just very time consuming. Now the way we do it is much better, computer controlled. We have leaves inside the head that move around, so it's much more advanced.
Much more focused.
Yes, correct.
That's great. You mentioned sarcomas, and I know when I was working doing claims for the 22 plus years, used to get a bunch of people come in and they had melanoma and they thought they qualified for one of the presumptive sarcomas. And I wondered if you might just briefly enlighten us on the difference between sarcoma and melanoma.
Sure, these are two really very different things, and they come from very different cell structures. Melanoma is a cell that lives in your skin, and it is the cell that gives the pigment to the skin. And it's in the deep layer of the skin, but it's not part of the muscle, it's not part of the tendons or the connective tissue, it's more within the skin itself. these things can go bad, and many times we associate melanoma with sun exposure. Veterans in the sun, military personnel in the sun,
Sure.
sort of a given. And these things don't behave very nicely sometimes.
Especially Navy, out there on boats without cover. I mean, you're going to get scorched by the reflection of the ocean.
Exactly, and those of us who were young and foolish at the time, not to protect ourselves, we got burned, and we all knew it, and we got through it. But now we think, hey, that was not a smart thing to do, because these things can be kind of nasty. The treatment is to remove them surgically, if you can, and with a very large margin. But they're hard to control because these things get out through the blood and can shower sort of everywhere and can land anywhere. A sarcoma is a cancer of the connective tissue, be it muscle, tendon, the fibers that cover the muscle, or the organs. And their treatment is much different, and their origin is much different because they're not really associated with the sun or anything like that. They can be slow growing, they can be fast growing, and they do tend to spread, some of them. We often see them going to the lungs. That's a very common place. And the treatment, although is the same, is also somewhat hard to do, because the treatment for sarcoma is surgery. That is the main treatment for surgery. Radiation doesn't work that good, chemotherapy doesn't work that good. The problem with sarcoma, if surgery is your main treatment, is the place that you have to remove. How do you remove a leg, or this thing from a leg, or from the inside of your body, without taking the entire thing? And years ago, that was the only way to do it. If you had a sarcoma in your extremity, they would take the entire leg.
Wow.
Yeah, there was no other way to do it. We now know we don't have to do that as radically as often. We can take large areas of the muscle per se, or whatever soft tissue is in the way, and take that plus a very large margin. But that does lead to some functional difficulties, because you have to take a muscle out of a leg, or something out of an arm. So those areas might be somewhat easier to treat. The areas in the chest, for example, are somewhat more difficult, because you can't take something out of your chest. You can't take the ribs, you can't take the muscles. It's hard to do. So they're very different origin and very different treatment.
Well, that's very informative, and I hope that clears it up for some of the folks out there. Certainly gives me a better definition than I had in my mind. Other than I really knew there were two different types of cancer, and where and what have you.
That's why we bring in the experts, people. You need to share this information. It'll be up in the archives in MP3 format. Send it around the globe. Whoever has boots on the ground in Vietnam, potential service-connected disability compensation based on some of these horrible diagnoses. Let's go over a couple more, Doc. Obviously, respiratory cancer is right down your alley, right?
That's correct. Yeah, we would see those on a regular basis. And basically what they're talking about is lung cancers, which encompass sort of a large area involving the trachea, the bronchioles, etc. But for the most part, we're seeing new lung cancers in the tissue itself. And we associate those with smoking, which is probably the number one association. And if you remember years ago, everybody smoked. Everybody did. They put them in there.
Smoke them if you got them.
Smoke them if you got them, exactly. It wasn't until the more recent times that we've come to realize, well, it's probably not a good idea. But we're still dealing with the after effects of that. These guys are still around, even from World War II, even though we don't see as many anymore. They're still here. And also the guys from the Vietnam and Korea eras are now coming with these diagnoses. And so, these are treated mostly with surgery, if you can do it. Another disease that's treated surgically.
Like a lobectomy type of deal?
Exactly. If you can do it, you have to take into account, of course, the patient's medical condition of whether they can tolerate something like that. Because if they've been smoking for 50 years, how do you remove part of a lung or all of the lung if they're not going to be able to breathe? And that's when I would come in, especially if they can't be removed, or if they're involving other parts of the lung that you can't get to, sort of the center area where the lymph nodes live. You just can't remove the whole thing because there's just too many structures there. So we try to combine chemotherapy and radiation together, usually in a curative form, to try to treat it that way if surgery is not the way to go.
What kind of symptoms should people look out for to indicate that they at least need to be checked to see if they have lung cancer? Because I saw way too many people who, by the time I saw them, I couldn't even get their claim processed before they passed away.
Yeah, the most common presenting symptom is going to be cough. Now, a lot of guys smoke and have a cough, so it's hard to tell. How do you know when that cough is not the usual cough. Well,
Are there markers that can be picked up in lab tests?
No, not really.
Wow.
No, we're not that good yet. It's mostly symptom directed and short, changes in the cough pattern, changes in what's coming up, the sputum if there's any blood, or just a change in the way it feels. Shortness of breath. If you're noticing that you're getting more shorter breath, that could indicate something is blocked off, or the lung is being compressed and you're not able to move much air. So those are the main ones you're going to find. Is going to be shortness of breath, cough, maybe weight loss. I'd be on the lookout for those things.
And if I'm hearing you right, you should at least maybe annually get x-rays of your lungs if you're a smoker.
And there is some data to support that. We're looking now at whether CAT scans, yearly CAT scans in high-risk people such as smokers, would be beneficial. There has been some pushback from some of the government agencies whether we need to do that on everybody because it costs money to do that, and they don't want to pay for those yearly CAT scans. We don't find them all, but the ones we do find, we can get them at an early stage. So right now, the movement is toward people who have a high risk of lung cancer, namely smokers. They may benefit from cancer screening with a CAT scan.
Well,
Folks.
also in those exposed to Agent Orange.
Correct.
Exactly. Folks, we're talking with Dr. Todd Panarese. He was a major in the U.S. Army Medical Corps. We're talking specifically right now about Agent Orange, presumptive service-connected disorders. Now, Glenn, we know there's a list of 15 some disorders. Some of them we can strike off the list because they had to manifest the symptoms had to manifest within a year after exposure, basically a year after they left service. And there's a number of them there. But what are some other ones that, in all your years of representing vets, came up rather frequently? I know one of them did.
Yeah, well, the prostate cancer, and that's very common in men. I think age 40 and above is a period when you're more at risk for that, even if you weren't exposed to herbicides, to Agent Orange. But prostate cancer was a very common one, and probably down your alley, Doctor, is some of the treatment regimes for that, because it used to be when I first started, it was surgery or surgery or surgery, and now there's radiation pills or something or whatever. And
Sure. I mean, prostate cancer in men is incredibly common. I'm not sure how they've linked the Agent Orange to the incidence of prostate cancer. I don't know how they did that, but apparently they do cover it now. So if you were exposed to Agent Orange and have a prostate cancer, you may be entitled to VA benefits. The treatment is going to be, well, it depends. There are a number of ways to do it. You can either do surgery, you can do radiation, and radiation comes in a number of flavors. Either we shoot from the outside to the prostate, or you can shoot from the outside in combination with putting radioactive seeds into the prostate.
Radioactive seeds, so you
Correct.
actually inject them into the body.
Yeah, we go through the space between the rectum and the scrotum, and we insert the radioactive seeds through that space and deposit them into the prostate. And the benefit of that is to put a very high dose of radiation into the prostate itself and try to spare the tissue that's around it. So instead of coming from the outside, we go directly from the inside. And so you get away from the hope is to get away from the prostate, the rectum and the bladder. So you don't put as much a dose to those areas and get a very high dose to try to kill whatever's inside the prostate.
do you have to go back and pull that back out?
No, those are yours to keep.
Okay.
Okay. And what's the success rate with that procedure for Vietnam vets that you've seen that have prostate cancer?
It's excellent, especially for early stage prostate cancer. If we're catching it early, they'll do the biopsy and they'll look under the microscope to see how aggressive this cancer is, and they'll give it a score. And if you have prostate cancer, you've been given a Gleason score, which tells me how aggressive this tumor is. 8 and above, we don't like to see. Those are the aggressive ones, and those would not be. We would not use seeds for something like that. 7s can go either way because they roll that dice 3, 4, 4 plus 3, either one. And then 6 and below are the less aggressive ones. So we want to have the low risk people will do the best. And really any treatment you do, either with radioactive seed implantation, external beam radiation therapy using what we call IGRT, image-guided radiation therapy, or even in good hands, a prostatectomy. They'll all give you equivalent outcomes.
And the there's no good thing about prostate cancer, but if you are subject to that, especially if you're a boots on the ground Vietnam vet, get your PSA, what's that, prostate specific antigen.
Correct.
Get that test routinely once a year?
It's usually once a year with your annual checkup. The doctor should be doing a PSA and a DRE, a digital rectal examination. Those are really the only two.
Dr. Jellyfinger, is that what
Yeah,
we're
that's
talking
the
about?
one. That's the one. Yeah, and those are the only two suggested or recommended screening tests that we have at this point for prostate cancer.
Folks, we are so running out of time here. We're going to have Dr. Panarese back when his schedule permits because there's so much more we want to talk about. We kind of covered some Agent Orange business, but in your career, you're not just a medical doctor, you're also a research clinician, and you headed up something that's near and dear to our heart, the Gulf War Syndrome. You were actually the chairman of the Critical Care Committee.
That's right.
Tell us a little bit about that while we've got a little time here.
Right. So, when I was at Fort Riley from '92 to '96, the Gulf War, had wound down, and we had all these soldiers coming back with all these complaints and symptoms, and nobody really knew what to do, what was causing them. Were they faking it? Was this a real thing? Because the government had denied that they were exposed to any kind of biological agent, any chemical agent, so nobody really knew. Being the hardhead that I was, the commander tasked me to put this all together. And so my job at that point was to put together a program to get everybody who had these symptoms, evaluate them, track them, and report to the commander who then reported it up the line. And that was the Clinical Comprehensive Evaluation Program, CCEP, that was at Fort Riley. Now that was where I was, that was my part of the world. And so me and a very dedicated sergeant and the medical hold guys were the foot soldiers for this, put together the computer programs and the organization to identify who these guys were, get them in on a very timely manner, send them for the appropriate tests, whether they be on site at Fort Riley or if we had to send them to Walter Reed, Fitzsimmons at the time, to get them evaluated, get the results back, report, keep a catalog of all these results.
Building a case, basically.
Exactly, to find out, was there any commonality? Was there anything that everybody was complaining of? Was there any specific thing that we should be looking for? While I was there, it was really a broad spectrum of things because most soldiers complained of they didn't feel good. Now, how do you evaluate don't feel good? That's incredibly vague. We would find odd things in the urine. Some people would say, oh, we've got bacteria in the urine, so we'd have to look at that. We would send them for sleep studies. We found an occasional tumor that may, that caused problems.
Just a constellation of symptoms and problems.
Exactly. We found a whole bunch of normal things that we would find in young people. But then there were other things that we could not explain. Why we've done all these tests, and they're all negative. We can't find any one thing to support this complaint. And so those were also cataloged, and those also went up the line. Now, eventually the government has said, yeah, we have a bunch of people who have a problem, and we have to really take care of them. And so the VA has recognized that. Now, it's still in the process of, how to best take care of those folks. And that's going to evolve. As time goes on, are we going to find any one thing or specific thing that we can relate to the Gulf War syndrome? I don't know, but that's going to be part of that evaluation in years to come.
And you were involved in building the foundation to establish this PGW illness.
That's correct.
And we applaud you for that. We're so running out of time already. Before we go, though, the Cancer Care Centers of Brevard Foundation has a really important event coming up a week from today. It's Striking Out Cancer. We got 30 seconds. Tell us a little bit about this.
Sure. The foundation is going to be sponsoring and hosting a day at the park here at the Space Coast Stadium. We'll be there handing out goodies, saying hi to everybody, and just having a good time at the game. And so, all that money, any money raised, goes to the foundation. The physicians, the practice doesn't see any of that. That money goes to help the cancer patients who may be in financial hardship to be able to pay some of their bills so they can come for treatment and not say, I can't come because I have to go shopping. We'll help them with their rent, maybe some food,
awesome.
So they can get it.
Oh, so that's the 29th. Come out to the ballpark. There's going to be post-game fireworks. Cancer Care Centers of Brevard Foundation. Dr. Todd Panarese has been with us, and hopefully you'll come again soon because you can see we barely scratched the surface.
Yeah, I'd love to.
Time flies. Glenn, as always.
Well, as always, let me give you the Veterans Crisis Line for veterans contemplating suicide or harm to themselves and for their families. 1-800-273-8255. Press 1. And as always, don't forget, thank a vet.